Welcome back to the Ninja Nerd Podcast. Today we're talking about sodium disorders, hyponatremia and hypernatremia.
Yeah, baby. This is going to be a really good one. I think a lot of med students will have a lot of fear just shaken into them whenever they hear sodium disorders, man.
It shouldn't be that hard though, right? I mean, your sodium's down, you take some sodium.
Yeah, I mean, in some cases you are definitely right, but yeah, it's a little bit more complicated, unfortunately.
It looks way more complicated, but I know you're going to make this super easy for everyone.
I hope so. I hope that at the end of this,
A breeze.
You guys are going to really, really understand sodium disorders. You'll be able to find any patient who has a low sodium and figure out what the heck is going on, how to treat them, and just the step-by-steps. And if you find the patient with hypernatremia, again, you're going to know exactly what to do. So that's the goal. Let's get into it, buddy.
Let's get into it. First off, is one more common than the other?
I would say hyponatremia is the one that I'd say to some degree I'm going to see a lot. Hypernatremia is something that you see a lot in the ICUs. Unfortunately, it's kind of a marker of poor management, though. Okay. And so usually whenever you see a patient who has hypernatremia, we see a lot in the neurological ICUs because they're inducing hypernatremia, but oftentimes it's because you're not giving the patient enough water. And so it's kind of a poor housekeeping kind of like measure, unfortunately, in an ICU.
But being that more things can go wrong, hyponatremia is the one we're more concerned about.
Yeah, hyponatremia is a pretty scary one. So I think
lots of bad things can happen.
It comes with the risk of cerebral edema and seizures and ICP issues. And so it's something that you definitely want to be able to recognize, identify, and treat quickly.
All right. Well, we have two cases lined up here. We're going to talk about hyponatremia, and then we're going to transition into hypernatremia, each one having a case series to go along with it and hopefully help you all learn. So let's get right into it. We have a 24-year-old female. This is going to first start with hyponatremia. 24-year-old female presents to the ED with a 2-day history of severe headache, nausea, and episodes of vomiting. The patient reports that she recently returned from a week-long camping trip during which she consumed some stream water. That's
Yucks.
A bad move. Maybe it was contaminated. Well, it seems like it is. She began experiencing watery diarrhea, repeated vomiting 2 days ago, which has not improved. She also describes a progressive throbbing headache and bouts of confusion. Past medical history, unremarkable. She's a pretty healthy young girl. Review of systems, neurological, reports headache, confusion, and a witnessed seizure before arrival.
Oh, wow. Okay.
What's that one making you think of?
Definitely is like a symptomatic hyponatremia, since we know that the patient has hyponatremia like off the case. If she's having headaches, confusion, and a witnessed seizure, this is probably going to be a terrifyingly low sodium.
Okay. Well, let's find out. GI, severe nausea and vomiting, inability to tolerate oral intake. Cardio, feels lightheaded upon standing, suggestive of some orthostatic changes.
Okay.
All right, let's talk vitals. Her blood pressure is 85/55. Heart rate is 115. Respiratory rate is 22. Her temp is 37.2 Celsius, and her oxygen sat is 98% on room air. For her physical exam, the patient appears acutely ill, distressed. Her neuro exam, her Glasgow Coma Scale, or GCS, is 14. That overall accounts for a I of 4, verbal 4, motor 6. She is oriented to person and place, but confused about the time. There are no focal neurodeficits observed, but the patient does appear post-ictal. Okay. Cardio, she has tachycardia with a regular rhythm, no murmurs or gallops present. Skin, dry mucous membranes, decreased skin turgor, indicating dehydration. And then finally, for her abdominal exam, diffuse abdominal tenderness, hyperactive bowel sounds. The sodium is 118. Oh my gosh. That's not good.
No.
That's not good.
That's not good.
Potassium is 3.5. Creatinine is 2.1. BUN 35. Glucose 90. Serum osmolality of 260. Urine sodium 20. And urine osmolality 450. Okay. We do get some imaging. We have a CT of the head. Shows signs of mild cerebral edema. No signs of hemorrhage or mass effect.
Okay. All right. Wow, this is a lot of information. She's got a lot going on.
A lot of information. Her sodium is really in the absolute crapper.
Yeah, it really is.
It does not look good.
No.
What do we have to do with this patient, and why is it so important to make sure we have a really good approach?
Yeah, so for this patient right away, I would consider her symptomatic, acute to the degree symptomatic hyponatremia, but more putting evidence and stress on the symptomatic hyponatremia, and then she also has severe hyponatremia. So any hyponatremia where the sodium is less than 120, that's kind of concerning. So I got a lot of things here. Like once I notice that a patient's acute, less than 48 hours, severe, less than 120, or symptomatic, she's having seizures, she's confused, she had headache, that right there is an indication for giving them hypertonic saline, which we'll talk about in the treatment section. I think the big thing for this patient, though, is figuring out what's the underlying cause. And so a lot of the times for your exams or in, the actual clinical world, you're going to be required to kind of investigate the underlying cause. The history is glaring at me and telling me the likely cause, but we can hit this in two different ways. And so the first thing that I notice right away is that she's had multiple bouts of diarrhea and vomiting. That means that she's losing water as well as sodium chloride from her vomitus, and as well as the punami that she's got going on. So there's a lot of volume that's being lost and sodium being lost from those sources. So it's likely that in combination with her not taking in enough food or fluids, that's the likely source of her hyponatremia. What I would also say is for her, when I look at the lab, so the way that we generally approach hyponatremia is we look at the serum osmolality. And the serum osmolality is designed to tell us if this is real or if it's not. So for example, hers is 260. That's low. If it was between 280 and 295, that's called isotonic hyponatremia. That's usually a lab artifact. That means that they probably have like high amounts of lipids or proteins in their bloodstream that are throwing off the correct number. And so I don't think that's the case. So it's not isotonic. And then hypertonic would be greater than 295. And that indicates that they usually have hyperglycemia, like a DKA, or it sometimes can be indicative that they got mannitol, like from an ICP crisis standpoint. So I think it's real because hers is less than 280. Hers is 260. The next thing I like to do is I like to look at the urine osmolality. And the reason why I like to look at the urine osmolality is it tells me if the body is really pumping up the ADH levels to retain water. Because if they're losing water, your body's going to try to go into this like disastrous protective mode and retain as much water as it can to replenish your blood volume. Because she's been vomiting and having diarrhea, I suspect her ADH is going to be kind of going up. And so then I look at the urine osmolality. Anything greater than 300 can tell me that she's concentrating her urine. So she's taking in as much as water as she can.
And she's well above that at 450.
Exactly. So right now I know it's a true hyponatremia and it's an ADH dependent process. And what that does for me right away is it gets a couple things off the table. If it's greater than 300, it's unlikely the following: beer potomania, which is when they're just drinking cases of beer a day, tea and toast diet, which you see in elderly, as well as primary polydipsy, which you see in schizophrenics. So those are kind of off the table. And then end-stage renal disease, that's another one. I've already ruled those out. So then I come down to a couple different thoughts. Okay, what else could it be? That's when I look at the volume status. So if I look at her volume status, she's obvious. Anybody could pick it out. She's hypovolemic.
Right.
And so I can tell that based upon a couple different things. One is when you mention her vitals, she is hypotensive, she's tachycardic. On top of that, she has signs of orthostasis. And then she also has dry mucous membranes, decreased skin turgor, and all of these signs suggest dehydration. On top of that, another thing that suggests hypovolemia is her acute kidney injury. She has an increase in her creatinine. They don't know what her baseline is, but that's a high one. That's a high one for a person who has no underlying chronic illnesses. And then on top of that, her BUN's a little elevated. So for me, I can tell right away she is the hypovolemic patient.
Now, I know we'll talk about this in treatment, but how important is it to replete her fluids as quickly as possible? Is it something that you're like, hey, this is a priority, let's move?
Yeah, so for her, priority right now, if I had this patient and she was having seizures or elevated ICP cerebral edema, it's actually going to be trying to get her sodium up kind of quickly. Generally, what the guidelines say is to bump it up 4 to 6 milliequivalents within the first 6 hours. After that, you stop and you start treating the underlying cause. So that would be the first thing I would do is I would give her 3% hypertonic saline, probably 100 cc's, see how she responds to that. Keep an eye on her sodium, make sure that it's going up, but I don't go up too quickly. Because one of the downsides is if you correct the patient's sodium too quickly by giving them a lot of hypertonics or fluid like a normal saline, one of the downsides is that you correct it too quickly, bump above 8 milliequivalents in a 24-hour period, you can give them osmotic demyelination syndrome.
And that's a bad day.
Yeah, exactly. And so that's something that you just have to be careful of. So for the patient, treat the symptoms first, get them to stop seizing, get the cerebral edema to come down, get it to no greater than 6 in a 6-hour time frame, but don't go above 8 in a 24-hour time frame. After that, you start slowly kind of bringing their sodium back up.
Okay.
So that's kind of the way I would approach that.
I know I spoiled the treatment there a little bit, but
That's
I
okay.
was curious how quickly you're trying to do all of these things.
Exactly. You got to be careful because if you go too quick, you definitely increase the risk of osmotic demyelination syndrome. But again, you have to treat the patient's symptoms, which is the cerebral edema is a big one. She's causing terrible headaches and probably some of her nausea. And on top of that, she's also got seizures.
Yeah.
So we got to treat that, get them to stop having those issues. And then after that, we start slowly kind of rising up her sodium with normal saline. But one thing I would say with this patient is she's hypovolemic. So she's hypovolemic. I got to figure out what's the source. And I don't need a urine sodium to tell me that, but you gave me one, which is nice. The urine sodium's low. So generally if it's like less than 20 or less than or equal to 20, we can say, that tells me that the kidneys aren't the one peeing out sodium.
And being that she's right at 20, she's right on the cusp there.
Yeah. So I would say that she doesn't fit nicely within a kind of a realm of what I consider a renal sodium loss. This is extrarenal. And I can tell from her history that it's coming from her mouth and her butt. Right?
Yeah.
So I know it's not coming from her kidneys. And so that right there is going to kind of nail down the diagnosis. If I had a patient who was euvolemic though, they didn't appear to be hypovolemic, then I'd be thinking something SIADH. And so I have to rule out hypothyroidism and hypocortisolism first. So I would check those. And if I had a hypervolemic patient, that's when I would think about patients like CHF, look for that history, or cirrhotics. So that's kind of the way that I go about approaching these patients at the same time, like you made perfectly clear, as I'm approaching the cause, sending off a urine osmolality, a serum osmolality, and a urine sodium. I'm also treating the patient's symptoms, which is I'm going to give this patient hypertonic saline, which is the big thing right away.
All right, cool. So I know there's a lot of complications that can go wrong in a patient with hyponatremia.
Yeah.
What are some of the big ones that you have to be aware of?
I think what this lady has going on right now is pretty concerning. So when you have hyponatremia, the amount of sodium inside of the bloodstream is less. And so sodium is supposed to maintain an osmotic gradient to a degree. If I have less sodium inside of the bloodstream, I have less ability to hold water into the bloodstream. And then that water crosses the blood-brain barrier, gets into the actual cerebral tissue and starts swelling it. Mm-hmm. And so that's when they start to experience cerebral edema, which her CT suggested.
Yep.
Some of the manifestations of that is they'll start off with maybe a headache. Maybe they'll have some nausea. Maybe they'll even have vomiting. They may have pupillary changes where they have like double vision, which is very common. Worst case scenarios, if the ICP goes up high enough, they can start developing evidence of herniation. So they can have brain tissue that's actually squeezing and compressing on the midbrain. And so the most common one is uncal herniation. So they start developing pupillary changes and weaknesses on one side of the body. And so usually that's one concerning finding is, are they having like weakness on the contralateral side and then a pupil that's dilated and not responding to light. So those are concerning. But I think another big one that's really bad is whenever this sodium gets really low, to less than 120, we see it irritates the cortex and it can cause firing of that cortex asynchronously and can result in seizures. So she's had a seizure,
right?
And on top of that, she's having some muddling evidence of high intracranial pressure from some cerebral edema. She hasn't herniated or developed signs of herniation yet, but she's got some headaches, some nausea, and some confusion. So that right there is pretty concerning for me, and that's what would trigger me to say she needs treatment right away.
Now, I know we've discussed the treatment a little bit here so far,
yeah.
But is there anything else you would do in her treatment, especially when you start seeing some of these complications almost becoming more evident?
Yeah, so 3 reasons why I would treat this patient. 1, symptoms. That's the most important. If they have symptoms, you treat. Doesn't matter really what the sodium is unless you have an alternative explanation for those symptoms. If you have no alternative explanation and they're having symptoms such as elevated ICP or seizures, you treat them with hypertonic saline, 3% generally. If it's acute, less than 48 hours, you treat. And if it's severe, less than 120, generally I treat.
Yeah.
So those are the 3 indications. If I don't have those indications there, then I don't go and touch hypertonic saline because I carry the risk of giving it and then increasing the risk of overshooting that sodium, that 6 to 8 in a 24-hour period, and I increase the risk of osmotic demyelination syndrome. And if I give them that, the patient can develop almost a locked-in state. Yeah. So you have to ask yourself the question, is it really beneficial? Make sure you're giving it for the exact right reason.
And especially in her case, it's absolutely required.
Exactly.
Her sodium is less than 120, and she's having seizures.
Yep.
She's in a bad spot.
Yeah, so for her, she's got 2 indications, and I would suspect even it's acute.
Yeah.
When it's not symptomatic and it's chronic, that's the patient who is super high risk and you can overcorrect them super quickly and develop ODS. And that's why you have to be careful that it's not chronic. If it's mild and it is not acute, again, that is the big things, and they're not symptomatic, Don't treat them because you have a super high risk of ODS with that.
Have you seen ODS before?
Once. Yeah, and it was actually
Scary.
a patient. Yeah, it was actually a patient. And so they don't usually, it doesn't become obvious right away. So it usually takes a couple weeks, 2-3 weeks. And they start to develop like dysarthria, dysphagia. They start to develop quadriplegia. They have an awareness of their consciousness, but they can't really move. And they even lose horizontal gaze, so they can really only move their eyes up and down. So it kind of looks, it's like a locked-in syndrome.
Right.
And so sometimes we can see that in these patients, but I saw it in a patient who actually had normonatremia, and they ended up giving too much sodium. They went into what's called diabetes insipidus, and they overcorrected, and their sodium went up to 170, and they developed osmotic demyelination syndrome.
Can you reverse that?
Unfortunately, no. So the damage will be done. Usually it'll show up on an MRI. When you get an MRI and you look at the T2 signaling, you'll be able to see a lot of evidence of demyelination on the MRI that suggests that too.
So it just shows how crucial it is to be absolutely sure and have those indications.
Yeah, I think that's the biggest thing, is make sure you have a reason as to why you're going to give it. And if you don't have a good reason, please don't give it.
Yeah.
Exactly.
Yeah, reasons given here.
Yep.
All right, Zach. So let's say this patient stops seizing, edema improves, you treated the symptoms, it's going well.
Okay.
How do we then treat the underlying cause of her hyponatremia as well as the other types?
Yeah, so that's set up perfectly. So this patient came in symptomatic, acute, severe hyponatremia. We gave her 3% hypertonic saline, pushed her sodium up, let's say 4 to 6 in 6 hours, but we didn't go above that 6 to 8 in a 24-hour period. So we got her to stop seizing. We improved her cerebral edema. Great. We figured out her cause and the process as well. Now we got to treat that cause. And that's why you want to be doing these things in tandem. So if you figure out a patient has hyponatremia, send off the labs and testing that you need to figure out what caused it. And then on top of that, treat it acutely. Once we've treated it acutely, we now can sit back, look at our labs and say, oh, this is definitely hypovolemic hyponatremia. What do? As you said, start giving them fluid. Preferably, normal saline is the best thing to give in this scenario because you're giving them sodium, chloride, and water. So you're going to replenish their volume and replenish their sodium and their chloride. So that's what I would do for this patient. I would just give them normal saline, but be careful. Same thing exists. If you give them normal saline and you start pumping their sodium up a little bit too quickly, you might have to stop, give them some water, bring the sodium back down, because again, you can't let that sodium shoot up above that 8 milliequivalent time frame within a 24-hour period. So you have to just be very, very careful as you're giving saline solution. You're tracking their sodium maybe every 4 to 6 hours. And so that's what I would definitely be doing here. I would say if the patient was like euvolemic, for example, that's when I'm concerned about SIADH. In that patient, I don't give them any water. I actually restrict them. So stay away from water, because the reason why is every drop of water that they take in, their kidneys are going to reabsorb. And they're going to retain that, and they're going to drop their sodium. So don't give these patients water. Don't give them any normal saline. You'll actually probably hurt them even more. So no water, no normal saline. The reason why is in patients who have SIADH, they will outsmart you. They will reabsorb all the water. They'll dump the actual sodium, and they'll drop their sodium even more.
And that's specifically for euvolemic hyponatremia.
Yeah, euvolemic hyponatremia. Most of the time, SIADH, do not give them as much water and limit water as much as possible, and don't give them normal saline. Best thing to do is that sometimes you can try loop diuretics. So, because the whole point of loop diuretics, like giving furosemide or torsemide, is because you're getting rid of water. And so if you get rid of water, you'll kind of concentrate their bloodstream and make their sodium go up. I hate these drugs, but Vaptans. Vaptans are kind of they're great in the sense that they're ADH kind of antagonists. So they'll block the ADH, and so they won't allow for you to reabsorb that water, and you'll dump the water. But they carry the risk of liver disease, and they also carry the risk of hypernatremia. So you can correct a patient's sodium a little bit too quickly in that. So I would just be careful. Free water restrictions first line, loop diuretics would be second line, and a Vaptan would be like the last one, but try to avoid those if possible. And the last one would be like hypervolemic. So if they're overloaded, best thing to do is get rid of the volume, and loop diuretics would be the best thing to do for that one. So that's how I would treat it. Hypovolemic, give them fluids, normal saline. Euvolemic, avoid water, avoid saline. Furosemide if you need it, and then Vaptan's last line. And then for hypervolemic, usually furosemide or any kind of loop diuretic would give you the treatment of the underlying cause.
Okay, great. So that's hyponatremia knocked out.
Yeah.
1 down, 1 to go.
All right.
All right, let's move right into case 2, hypernatremia. We have a 34-year-old male presented to the ED with severe confusion and extreme thirst. The patient has experienced a dramatic increase in both thirst and urine output over the past week. He describes his thirst as unquenchable, estimating his water intake to be more than 8 liters per day.
Oh my gosh.
My gosh. He has also noted a significant increase in his urine output, which includes frequent nocturnal awakenings during to urinate.
That sucks.
I would have to imagine, right? You're going to have to get rid of it at some point.
Yeah.
Over the past 2 days, his family observed that he became progressively confused and now disoriented, which prompted them to seek immediate medical attention. Past medical history, unremarkable, healthy young guy. Vitals, blood pressure is 135/85, heart rate is 80, respiratory rate is 18, temp is 36.7 Celsius. For his actual exam, general, patient appears distressed, severely dehydrated. Neuro, markedly confused, disoriented to time and place, unable to focus during conversation. His skin, severe dry mucous membranes and poor skin turgor. And cardio, normal heart sounds, tachycardic rhythm. So some lab testing. He has a serum sodium of 162, big time hypernatremia. Serum potassium of 4, creatinine of 1, BUN of 14, glucose 95, osmolality 330, urine specific gravity 1.005, urine osmolality 280, and a water deprivation test result, urine osmolality after dehydration of 300.
Okay.
DDAVP challenge test results, urine osmolality after DDAVP administration 650. A lot of information there, but Zach, how do we kind of boil this down and approach a patient that has hypernatremia?
Yeah. So kind of similar to hyponatremia, you look at osmolality, right? So for hyponatremia, you look at serum. That's the first thing to see if it's real. Then urine to look at if ADH is on or ADH is off. And then urine sodium to look if it's extrarenal or renal. For this one, I don't even bother checking the serum osmolality because if a patient has hypernatremia, their serum osmolality is going to be elevated. So it's a waste of a test. Don't even check it. For me, the urine osmolality will give me an idea if a patient has what I am concerned with, which is diabetes insipidus or not. And even like diuretics as well. So osmotic diuretics would even be another one. So for me, I would check the urine osmolality. So if it's less than 600, what that tells me is that the patient is kind of producing more of a dilute type of urine. It's 280. So if it's 280, it's definitely super dilute. So right away, I'm concerned that they have a renal kind of source for their water loss. So that's the first thing I would check out. The other thing that I would do is I would say, okay, let me look at their volume status and see if there's anything in their volume status that kind of suggests if they're hypo or euvolemic or hypervolemic. And so when I look at this patient, what do you see, Rob? I see kind of a patient who's pretty dehydrated. They got dry mucous membranes, poor skin turgor. I'd say this patient looks like they probably have some type of hypovolemia present. And so from there, I would think, okay, there is usually osmotic diuresis causes that can lead to this, but also in some cases, like severe diabetes insipidus, that can also cause hypovolemia. So that's where I would want to be trying to consider is what is the likely cause here? So here's where the information gets a little bit more helpful. I look at the information and what I notice is I notice that you got me a water deprivation test. So the urine osmolality after they dehydrated the patient stayed pretty dilute. So it's less than 600. That tells me that this is DI pretty much, or osmotic diuresis. So I'm still kind of like in that range. The DDAVP challenge test is what nailed the diagnosis for me. When you give a patient DDAVP, you're giving them ADH. If you give them ADH, theoretically what will happen is their kidneys will respond to that and reabsorb water. And if they reabsorb that water, then you're not going to have as much water going into the urine, and the urine should become concentrated. And that's what happened, is they went from 280 to 650, so it shot up.
Right.
That right there tells me that this patient likely has central diabetes insipidus. So that's what kind of gave it away for me. As I looked, the patient has a serum sodium of 162, so it's greater than 145. Urine osmolality is low. It's less than 600. That means it's a renal water loss. They're hypovolemic, and usually here's where it's a tough one. Diabetes insipidus in a perfect world is usually euvolemic, but this patient seems to be more in the hypovolemic camp. So not everything's perfect. Water deprivation test, the whole point of that is ruling out a disease called primary polydipsia, which is in schizophrenics and hyponatremia. The urine osmolality stayed dilute. And so this definitely for this patient, it's definitely DI. And to figure out if it's nephrogenic or central, I look at the DDAVP challenge test and it shot up. So for this patient, it's 100% central diabetes insipidus. It's unlikely osmotic diuresis. It's unlikely any other kind of cause like a hyperaldosteronism of sort. That's kind of a rare one. That usually would have a patient who's super hypertensive actually, and would appear more hypervolemic. And there's no evidence here of the patient having any vomiting or diarrhea or anything like that. So it's unlikely like an extrarenal loss. So this patient definitely seems like they have diabetes insipidus, preferably central diabetes insipidus. And so with that, I would have to figure out what's going on with their pituitary or the hypothalamus. Did they have some type of trauma? Did they have a surgery? Do they have some type of like injury to their actual brain in that particular scenario that's causing them in this situation to not be able to produce enough of this ADH? And so that's what I'm suspecting here for this patient.
So let's talk complications with a patient that potentially has central DI, it's hypernatremia. What do you see and what do you want to really look out for?
So for this patient, I would be worried about him having some kind of encephalopathy. That would be definitely a big concern for me. I think that he's already showing some signs of encephalopathy with the confusion and lethargy. There is some pediatric literature out there that does say that patients who have hypernatremia can develop like subdural hematomas or intracranial hemorrhages, but that's usually in young patients or patients who are a little bit older and have a lot of atrophy. The concept behind that is if you have a hypernatremia, the sodium inside of the bloodstream will pull water out of the brain tissue and shrink it. And if you shrink it, you may tear those bridging veins and cause a subdural or maybe even intraparenchymal hemorrhage. So that's a possibility, but oftentimes it just causes confusion. The biggest thing that I notice with hypernatremia is, have you ever had like a lot of salty kind of like foods? What's like your natural desire after you have like salty foods?
Got to drink some water.
Yeah, you're thirstier than you've ever been in your entire life,
Exactly.
right? So
yep.
polydipsia is kind of a very strong kind of consideration here, is that this patient is super thirsty after drinking 8 liters of water a day. It's because they're trying to replenish what they're losing from their urine. And so that's a big compensatory mechanism that is telling me that they are really trying their best to try to correct their sodium. That's why hypernatremia is kind of a tough disease to have, because if you have the capability to drink water, you will, and you'll correct your sodium. That's why hypernatremia, oftentimes we see this in patients who have some form of water loss, either osmotic diuresis, diabetes insipidus, they're pooping or having lots of vomiting, and then they're not drinking water. And that combination of water loss plus lack of water intake is usually the primary driver of a patient developing hypernatremia. There's super rare ones out there like hyperaldosteronism, where you just reabsorb lots of sodium, but it's not as common as the other patients where they're peeing it out, pooping it out, vomiting it out, or they have diabetes insipidus. So that's usually the primary offender, is lack of water intake plus excessive water losses.
So is that why we might see this one more so with maybe elderly or people who have like neurodeficits, because they're not doing what they should be doing?
Exactly.
Which is taking water.
Yep. That's the population that we see this in a lot of, is elderly individuals or geriatrics, patients who are altered, confused, have Alzheimer's. You can even see this in the pediatric population too, because they don't have maybe that ability to grab or access the water.
Right.
And then socioeconomic areas, or areas where the lack of water is potentially available. Mm-hmm. And the reason why I say the ICU is intubated patients. They can't drink water and they can't ask for water.
That makes sense.
That's usually why we see it a lot in the ICU.
All right, so let's say we replace this patient's free water deficit. Mm-hmm. How do we then treat the underlying cause of his hypernatremia?
Yeah, so in this patient, we got to treat the free water deficit, right? And so there's a lot of like different ways that you could do that. The best thing to do is you can use a formula. It's the free water deficit formula. You can plug it into MD Calc, and all you do is you just take their total body weight, so the amount of kilograms, and multiply by 0.5 if it's a female or 0.6 if it's a male. So for this one, I would take the total body weight. Let's say that the patient's 70 kilograms, you multiply by 0.6, and then what you'll do is you multiply that by their sodium divided by 140 minus 1. And it'll give you a volume. That volume that you're going to give them is what you'll give to them over a 24-hour period. So let's say that's 4 liters. I have to replace 4 liters of water to that patient and give them 4 liters of water over a 24-hour period to replace the water that they're losing. That's only to replace the water that they're losing or they're in a deficit in. And so that's what you have to do. And while you're doing that, you're treating the underlying cause, as you said.
Okay.
So for this patient, as long as they're able to, I prefer the best way to get water is for the patient to drink it. If they can't, because as you pointed out, they're confused, they have something going on where they don't have the ability to drink it, they're altered, they have dysphagia, and they're at risk for aspiration, that's when I would take like an OG tube or an NG tube, put it in, And then from there, usually use that as the way of being able to give them oral water. In patients who maybe don't have that ability and we have to kind of maybe give them a little bit of water more quickly or just pure right into the actual bloodstream, that's when I would do IV D5W. That's a preferred option in certain scenarios where it's severe or they're not responding to that enteral or oral water solutions. But that's what I would do. So I would figure out what their free water deficit is and start giving this patient that water. Let's say that I give them 4 liters over a 24-hour period. Then at the same time as I do that, I have to figure out what's the cause. I already figured it out. If it was hypovolemic, hypernatremia, I would give them fluid back. So I would give the patient fluid. Usually, believe it or not, you give them like LR or normal saline to improve their hemodynamic stability. And then just from there, stop. Just keep giving them water. If it's euvolemic and it's central diabetes insipidus, guess what you got to give them? What they're not making, ADH. And so that's where I give the patient DDAVP. So for this patient, I would give them DDAVP and have them drink water. Weird one in nephrogenic DI, it was always so weird learning it, is you give them a diuretic. That sounds weird, right? If a patient's peeing out a lot, I'm going to give them a diuretic.
Yeah, it's a little odd.
So thiazides, basically, you give it to a nephrogenic DI patient because you're going to cause them to pee out sodium and water. You'll deplete their volume just a little bit, which will trigger the renin-angiotensin-aldosterone system to kick on and to reabsorb sodium and water across the kidneys and a way of being able to reduce the polyuria. So do that, and then in combination, give them water. And the last patient is kind of like your hypervolemic patient. And that one, you're going to give them furosemide. So usually like furosemide, like a loop diuretic, plus or minus a thiazide diuretic for this one as well. You're getting rid of sodium in this patient and also some water, but you're also going to give them free water by giving that. Again, every patient, you treat the free water deficit and treat the underlying cause at the same time. So free water, hypovolemic, you give them normal saline LR. Euvolemic, DI, you give them DDAVP or thiazides. Hypervolemic, you give them loop diuretics or thiazide diuretics. So that's the way I would treat the underlying cause and replace their free water deficit.
Easy as that, right?
Yeah, I guess easy as that.
That was awesome, Zach. Thank you. That is our episode on sodium disorders. I thought it was really cool.
Yeah, it was nice. And I think this is a tough one. And I know that if you guys are out there listening to this one or watching this one, just remember, take your time. You're not going to possibly get this the first time. You may have to continue to keep reviewing it. But I think the best thing for those of you who are students and you're trying to learn this topic or you're clinicians is to just keep developing a good systematic and diagnostic approach to every type of disease. Figure out what works for you and make sure that you stick with that. But man, this was a great podcast. I had some fun. Did you?
It was awesome. I really liked it. And I think it's time for the send-off.
All right. Well, Ninja Nerds, thank you guys so much for listening to this podcast. I hope that you guys enjoyed it. I love you guys. Thank you guys. And as always, until next time.